My name is Scott Tauber. I'm just going to be your presenter for today. And I am the Chief Clinical Advisor at Personal Injury Connection and the Driving Force Company. We're going to talk a little bit about why providers are missing this injury and why it's not necessarily being implemented into claims, and it's affecting case outcomes significantly. So since this is kind of a diverse group that's going to be joining us, attorneys, paralegals, providers, I have to start off with just a little bit of background about the spinal ligaments. There's over 200 spinal ligaments, and hence the name. They hold the spine in alignment. And like any other ligament, they have certain pathologies, and they have certain histologies, and they're susceptible to injury. Now, these ligaments get overstretched in trauma. So this is not an injury where you're going to have a client or a patient go, well, I played golf over the weekend, and then they get diagnosed with a spinal ligament injury. This is a traumatically induced, and this is all documented in literature, and I'll show you some as we go along. But everything that I'm going to be sharing with you is well supported, documented in literature, standard anatomy, standard physiology, in the AMA guides, learned treatises. And so these ligaments get overstretched, and one of the most common is motor vehicle crashes. And so patient clients have these injuries. These ligaments get stretched, but they don't get torn necessarily, and that's why it's called a subfailure injury. And this is in addition to any possible disc pathology. Now, I know in the med legal arena, everybody goes straight for MRIs. MRIs is where we look at the disc and we look for spinal swelling, but there's more to injuries in the spine than just disc and or fracture, dislocation, or anything like that. So as a provider, I can share with you, if one of you came to see me as a patient after a motor vehicle crash, this is what I would do for you. I would go ahead and do my initial evaluation and then do some x-rays, just pretty much like every provider would do, to rule out any fractures or dislocations or anything major that would be a contraindication to a form of treatment. And go ahead, and if all's clear, then go ahead and move forward. And then at some point, we would start to think about, if a patient had ongoing pain, we would think about an MRI for a disc. But there's something that's even more important that's going to actually show up more frequently and literally takes less force to actually injure a spinal ligament than it does a disc. And I'll come back to that concept in just a second. Now, what we also know about these ligament injuries in the spine, these occur in a very high percentage of personal injury cases. Because it takes less force to actually injure a ligament, you're going to get more ligament injuries than you actually are going to get disc injuries. Ligament injuries also have a tremendous permanent impairment and disability potential. So if your client or your patient may have permanent impairment, which is significant in the PI space, it's a huge value driver. Spinal ligament injuries require future care. And you'll see here in just a second from a former high-level auto insurance executive here, their quote. And in order to evaluate this particular injury, you need a motion or a functional test. And if you know anything about an MRI, which obviously most people do, that's not a motion test. You're encouraged to lay there and to be as still as possible. And in fact, sometimes breathing is discouraged, especially on the higher level three Teslas, because they'll go ahead and affect the outcomes. But in order to get this injury into the records, it has to be documented, but it also has to be objectified and quantified. And that's where we're going to show you how this all happens. A couple of quick other facts. When somebody has this injury, their spine is literally moving too much. So when they move, their spine moves too much because the ligaments are not holding it in place. It creates what's known as adjacent segment disease, which is a real disease where if you affect one area of the spine, areas above or below over time are going to show wear and tear, degeneration, and begin to affect the disc where it may not have been affected initially. Patient clients are going to have long-term problems, And all of this has been diagnosed in multiple versions of the AMA guides to permanent impairment. Now, every day, clients and patients involved in motor vehicle crashes are getting undiagnosed. They're getting misdiagnosed as simple sprain strains, or they're getting underdiagnosed. And this is something that providers and attorneys should be aware of. Now, just basic physiology, the ligament is overstretched. Hyperextension, which is what we know happens in a motor vehicle crash, has been proven to cause damage to the anterior longitudinal ligament and the facet capsular ligaments. And this comes right out of Spine Journal. 50 to 60% of those that have chronic pain have these injuries as their source of pain. And we know from multiple years of literature that more than 50% of people involved in motor vehicle crashes will have chronic pain. And this is one of the reasons why. This is what a damaged ligament looks like under an electron microscope. On the left is a normal, and on the right is a damaged ligament. And when somebody has this going on in one of their spinal ligaments, it's a problem. It causes their spine to be unstable. It's not as strong, and it's susceptible to being injured at lower forces and degeneration. So this is a problem long-term for clients, and we'll share that with you and get into more detail in just a minute on that. Now, this comes from, some of you may know James Mathis, who's a former superintendent for State Farm. He literally did a presentation for us last week, and this comes prior to last week, but he was doing a presentation for 90 minutes about ligaments. This is a direct quote from him. In the area of a disc injury, so as a provider or an attorney, if you have a patient that has a positive disc on an MRI, whether it's a bulge, prolapse, or herniation, the spinal ligament needs to be evaluated in addition to that particular test to help add case value and provide documentation, objective evidence, and causation of the disc. So I want you to think about this. If your client has a disc, and I just told you that it takes less force to injure a ligament than a disc, right? So here's our logic. If we have a disc injury, then we must have a ligament injury, because the ligament has to be injured on the way to actually injuring the disc. So that's number one. Now, as a provider, if you're sending your patient out for an MRI and it comes back negative, well, then you have to keep digging and figure out what's the underlying pain generator, since it's not a disc. So that's why a motion or a VMA, which you'll see here in just a second, to evaluate the spine is important as well. So both of these tests have to be done, and at least the spinal ligament testing should be done. The ligament damage is forever. It requires palliative and curative treatment, but it is a forever injury, and that's another direct quote from him. So when your patients or your clients come to see you for the first time, and you're sitting down and you're talking to them about the mechanism of injury and the mechanics and all of the things related to the crash or accident, and you're asking them about how they feel and documenting their symptoms, these are the symptoms of a spinal ligament instability injury. And you'll notice these are the symptoms that the majority of your patients and clients are going to be complaining of: headaches, spinal pain, neck and back, stiffness, weakness, restriction of motion, and possibly tingling and numbness. And again, you might want to jump, okay, let's do x-rays and then an MRI, but we want to do the spinal ligament instability testing as well. So these are a very common group of symptoms that nearly every single patient client is going to have. Now, let's get into some specifics here. The current standard, which unfortunately is not as accurate, reliable, and in fact is outdated, is to take standard x-rays. The problem with taking standard x-rays is that the patient is uncontrolled. They just move, they bend forward, what's called flex X, forward bending for either the cervical or lumbar, and extension. It's difficult to truly isolate the spine when your patient is just bending. Now, the other issue, there's only 2 to 3 images that are produced, and there's a very significant chance of missing injury. So even if you're a provider and you're looking for this injury and you're using x-ray, there's a good chance you're missing. If you're an attorney and your providers are using x-ray, there's a very good chance that they're missing a significant amount of injuries. And isn't really that the point of doing a test, is to try and find and to be as accurate and reliable and consistent as possible? And the answer to all those would be yes. And it's not just me saying this. This is published literature from the International Journal of Spine Surgery, where they compared X-ray to what's called VMA, which you'll see in just a second, which is the new standard medical technology advancement in identifying spinal ligament. And basically their conclusion was, with regular X-rays, this injury goes missed and underdiagnosed. And with the red underline, the current standard, results in increased interpatient variability, which means it's just not as accurate. Their conclusion was that there is an increased measurement variability when relying on diagnostic imaging for diagnosis. The measurement variability was reduced when including vertebral motion analysis, again, from the International Journal of Spine Surgery. So now there's a way for you to help your patients or your clients improve their diagnosis specificity by including an additional diagnosis in addition to whatever else is going on, in addition to a disc. Identify this spinal ligament injury accurately and consistently. If you're a provider, this is going to help you improve your patient care and your PI outcomes, because when you have a better diagnosis, you have a better treatment plan and better treatments. And it's going to improve your med legal case outcomes because it's another diagnosis, it's another injury that goes into your demand package in addition to whatever else that client happens to have and or be diagnosed with. Now, this technology that you're going to see is already FDA cleared, it's patented, and no one else has it. It's proprietary, and it's called the vertebral motion analysis. It uses two different machines. It uses a C-arm or video fluoroscopy, and then also another, and you'll see this here in just a second, you'll actually see a video of it. It uses what's called a motion normalizer analyzer that captures the spine in real time. And remember, I said you need a functional or a motion technology in order to see this injury, and this is exactly what this is. It's designed specifically for this injury. And again, this is an advancement in the medical technology beyond the standard X-ray. And we've had medical neuroradiologists, multiple, look at this. And basically their input is, this is extremely valuable technology and the best way, not just a good way or a way, but quoted, the best way to demonstrate an instability lesion, much better than the old standard of 2 to 3 X-rays. Now, this technology, while maybe new to you, has actually been around for a while. It's already been featured on the Today Show on the left. You see it there, that they're using it in a segment for lower back pain. And it's already been published in peer review, the Spine Journal, which is the gold standard for anyone or any healthcare provider working on the spine. So it's already been published and won the outstanding paper runner-up. It's a painless test, it's accurate, it's consistent, it's reliable, it's objective, and it's quantifiable. And you can literally see the spine move in real time, capture that injury, and then present it, if you're an attorney, present it to the insurance carrier. So let's go ahead and take a look, and we'll see a couple of different testing, one with the cervical and then one with the lumbar. So
the Vertebral Motion Analyzer, or VMA, is a system for assessing spinal motion, including lumbar and cervical radiographic instability. The VMA is an alternative to the standard flexion, extension, bending X-rays that are currently used to assess spinal motion and instability. The VMA uses special patient-conforming hardware to assure patients fully bend during imaging. There are two key hardware features that promote consistency and reliability: the bolsters and the controlled motion. The bolsters keep patients from bending at their hips to assure that the back and not the hips are in motion during imaging. Current testing methods tell patients to bend on their own without constraint. Thus, they often bend with their hips versus their back. The cervical VMA operates on the same two principles as the lumbar configuration: bolsters that minimize torso motion. Then the patient follows the device through a controlled flexion and extension.
So here you see what happens when a patient gets a standard cervical x-ray. They're just free-form bending.
This controlled motion provides a tactile guide for patients to be assured they bend sufficiently during imaging. The device and patient are imaged by the C-arm, which produces video-type X-ray images of the controlled bending.
So there's a couple of key factors there is that the patient is literally bolstered in so they can't recruit other areas of their spine, or for example, for the lower back when they're bending, a lot of times patients, because they can't bend, they'll bend with their knees just to try and compensate, they'll arch their back, they'll do all kinds of crazy things. But when you do that, you're not isolating the spine, and therefore you're going to miss a tremendous amount of injury. And of course, we're not forcing the patient to do anything, and we're capturing the spine in real time. So the advantages with using the VMA is we can control the patient motion, allowing them to move and bend sufficiently. We can isolate the cervical and lumbar. Instead of 2 to 3 x-rays, it's actually 150 images evaluated throughout. And we literally have an increased opportunity to identify this injury. Again, compared to the old way of using standard radiographs or x-rays. Now the reports, which I'll show you in just a second, which is important. Once a patient goes through the testing, there's multiple reports, and I'll share with you them in just a minute, as I mentioned. It measures the ligament translation and angulation, which is the two ways that this injury is identified, and it also measures disc height as well. So that's significant. Here's an actual case, and I want to share with you a couple of different cases here. This is an actual case that's been done in one of our offices. And on the left, it's just a screen capture. But the point is, you couldn't tell if this patient had a ligament injury or not, just by looking at this spine. In the middle with the 2 red arrows, that's where our team has gone in and done a markup. It's independent. It's not done by anybody in the office. So they're not, fudging or moving the numbers around at all. This is an independent, neutral third party that does the markups, that's showing an issue. When you go over to the right, this patient has a 3.5 and a 3.6 millimeter translation. That's significant. Why? First of all, anything greater than 2 millimeters is a problem, but 3.5 millimeters or more in the cervical spine, just like this patient has, is permanent impairment. And that is a whole game changer when it comes to the settlement evaluation and what you can bring to the insurance carriers. And here's a quote from somebody that we work with. The VMA reveals injuries and spinal instabilities that may be invisible on standard X-ray or MRI, and functional radiography is the future when it comes to diagnosis and treatment. But it's not the future anymore, it's actually right now. And it's in multiple areas around the United States. I want to share this with you as well, because if you're an attorney or a provider, actually, this should really kind of worry you. First of all, this was published on the right-hand side. This is another literature study that came out of Spine Journal. Some of you may be familiar with it, about MRI. And we all think that MRI is truly objective and it's going to show us and it's going to be the answer to all of our problems in personal injury. Well, unfortunately, the answer is no. This study sent one patient, a single patient, to 10 different MRI centers to get an MRI over a 3-week period. And the results were that it's not as objective as we would like to think, because the whoever interprets it has an impact on the diagnosis, the choice of treatment, and the clinical outcome. There was such variability in the MRI. One patient, it should all be standard. If one patient is getting an MRI, it's the same patient, but it wasn't, and that was a problem. So MRI is not quite the gold standard as we would like to think. Now, this is an actual case study. This is a medical doctor. Her name is Dr. Ebony. Her first name is Ebony. And she was in an accident. She was in Texas. She got into an accident and she was having hip and lower back pain. And during the course of her treatment for her motor vehicle crash, she was sent out for 3 MRIs, all of them coming back negative. They couldn't find the pain generator. Well, ultimately, they had to settle her case, but she was left with ongoing pain. Now it's chronic. Now her case is settled, but she's still in pain. She came and got this test done. She heard about it, got the test done, and guess what? It showed that she had a 4.0 and a 4.3. These are literally her results, as you can see over here. This is her first name. This is the patient right here. Her first name is Ebony. A 4.3 and a 4.0. That the underlying pain generator in her PI case was a spinal ligament injury and instability. She could have gotten an MRI every day for the rest of her life, and it still would never have found this injury. She took these results to her representing attorney, even though the case was settled, and said, "What would you do with this?" It changed everything from a average settlement to a 6-figure settlement with now an objective finding and something to bring to the carrier to show. If you're an attorney, how do you justify 3 MRIs all negative to the carrier? How do you present that? That's a problem, right? I mean, you may even think that they may even think, and you may even think that the patient is a symptom magnifier or embellishing, or it's all in their head because, hey, nothing's coming up on MRI. Why are you still having this pain? Well, guess what? Unless you run this test, you'll never find this injury. Now, here's the other cool thing. Remember I told you that the VMA can identify disc height? This far right column says disc height, and it can measure the disc height in millimeters. Look at this. This is 9 millimeters. This is literally her best disc. It's 9 millimeters in height, but it's her worst ligament. So what does that mean? That means on MRI, her discs look pretty good over here. And anything over 2, so even though these are 4.3 and 4.0, she even has a problem down here at 2.6. So what I'm sharing with you is something that no other technology is going to find to this level, to this consistency, to this accuracy, to help your clients and help your patients. And as I mentioned, when the test is done, it's a very easy, painless test, 20 minutes. Your patient clients get it done. Reports are generated. You have access. And then we send the reports out to an independent, neutral, third-party neuroradiologist for verification and validation to make sure everything is correct. Now, not to bore you with literature, but all of this and everything that I've been saying is validated in the literature. The VMA is more sensitive than X-ray. Published literature showing anywhere between 41 to 44% greater chance of detecting instability. And on the right, in studies submitted to the FDA, able to quantify it down to the 0.5 millimeter. So all of that is significant. All of this is again in the AMA guides to the evaluation of permanent impairment, both 5th and 6th edition. This is even in here, this is described as a traumatically induced injury, and that absent trauma, this injury is rare. So when you start putting all of these puzzle pieces together, and especially in the PI space, you now have a very powerful injury that's being missed, undiagnosed, underdiagnosed, missed, and certainly not getting into demand packages because you know as an attorney, If it's not in the records, you can't use it. And this comes right from the page in the AMA guide showing this is a 25% whole person impairment in the cervical. This is page 379, showing 3.5 millimeters or 11 degrees of translation. So I see we have some questions, which are good, and I will answer those in just a second. So let me just share with you a couple of things here. Long term, as an attorney, when you put into your demand package, long term, how is this going to affect your client? First of all, we know that ligaments, and if you've ever had a ligament, it doesn't have to be a spinal ligament. If you've ever had a sprained ankle, knee injury, ligaments take a while to heal. And the reason why is because the way things heal in our body is through blood supply, and ligaments have a very poor blood supply, and that's why they heal poorly. That area is going to be predisposed to re-injury. As I mentioned, it's weaker. The spine, if in a spinal ligament, it's unable to tolerate lower forces and loading. Your clients are going to be predisposed to re-injury. We also know that the client's going to have accelerated spinal degeneration. And remember that adjacent segment disease above and below those areas over time. That's just the way the spine works. When you affect one area, areas above and below then either have to compensate or work extra, and over time, it's just going to cause degeneration. We do have the possibility of permanency, and life care planning and future care and expenses can be included, obviously, if the case warrants that, and depending on case-by-case basis and policy limits. So these are significant on what's going to happen to your client over time and long term. Now, as providers, it's great to be able to diagnose it, and it's also great to be able to identify it, but you also want to try and treat your patient as well. So this all depends on specialty. Obviously, anywhere from chiropractic to physical therapy to pain management to orthopedics to whoever's doing injections to even possibly a spinal surgery consult. Remember that patient that was 3.5 and 3.6? That's a spinal surgery consult case, because that is significant instability in that area. Dr. Ebony that you saw was 4.3 and 4.0. 4.5 in the lumbar spine is permanency. So she was bordering on that. So there are treatments available. PRP is very good. Spinal strengthening can be beneficial. Surgery is an option. And there's also implants reactivate muscle strengthening that could be done as well. All right, so now I know some of you are in Utah. This is already in Utah. This is Dr. Richard Allen. That's me on the left. And he's in Draper Wellness and Neuro Center. And so he's doing testing already. And so if you have clients, he's available to do, or patients, to see your patients and clients to get them tested for this. So he's already in Draper, and more are coming as well. So let's see, we're going to go in here and see if we have some questions, and then we got a couple more things just to kind of cover here. Okay, so we have, okay, good questions. How soon post-injury should this be performed? All right, so there's a couple of answers. I'm going to answer it like an attorney. It depends, right? Okay, so I'm just kidding. All right, so how soon? In an ideal world, so if you have a client or a patient, this should be done within 30 days, ideally. Now, we realize that there might be some cases that are past that, right? You may have a client, if you're an attorney, that's been released from care and is still complaining, like Dr. Ebony. She was released, but she still had problems, but you still have to try and settle the case, or something along those lines. It could be done later, but that sweet spot is right about 30 days. If you're a provider, I want you to think about right around that first re-examination. So another question was, do we have an example of what the full report entails? Absolutely. I'll give you my email address, and if you shoot me an email, we can get you out sample reports and everything that you need. So would there be a way to know if this was pre-existing? That's a really good question. Now there are some ways, but it depends on also, so let's answer that a couple different ways. Say this patient or your client has this identified now and never had this testing done, and they were in an accident 10 years ago. How do we say that it wasn't from that accident? Well, we don't necessarily know, but as an attorney or a paralegal or a med-legal professional, that your clients come with pre-existing, and we do have to make an argument. Like they can even have pre-existing disc issues as well. So we take our clients as they are, but we do know that you're not going to get spinal ligament instability from old age or from just standard degeneration. We already know that carriers like to say, well, everybody over 40 has a disc, right? Okay. But this patient or client could have been asymptomatic. That's where pre-accident medical records come in. They could have been asymptomatic, but not for this accident. They could have gone the rest of their life. So yeah, the pre-existing and how do we know? Yeah, it's a little dicey, but it's like any other pre-existing as well. Now, there are a couple of things that you can put in there. There's an exacerbation and an aggravation as well. So you can put that into your demand packages as well. A couple of other questions. Good. What is the cost of the VMA exam and report? Right. So in Dr. Allen's office, he is charging $2,600 for the examination, all the reports, and includes the independent neuroradiologist as well. Have you experienced admissibility issues on this in other jurisdictions? We haven't. We've had other attorneys basically take these cases, and there hasn't been any issues. A lot of these cases actually settle. So when I'm sure I'm preaching to the choir here, I know, and with attorneys, when you have objective findings and you bring it to them in a manner that the carriers understand, sometimes cases will settle. So you don't necessarily have to get into litigation. I mean, but that's not always the case. But to answer your question, we haven't had any admissibility issues with this technology. So these are good questions. Appreciate that. Let me know if anybody else has any other questions. And so currently we're in 8 different states, Utah being one, and we're continuing to grow. This is one of our latest launches here in Control Imaging in Beverly Hills, which is a diagnostic center. Over on the left, you can see what it actually looks like. So it's our FDA. All of this is FDA. The FDA tower, which you see on the left, that the white or tan tower is part of the C-arm, and then the motion analyzer and everything. So it doesn't take up a whole lot of space, approximately 150 square feet. And this is the team that's over in Beverly Hills. So I know, Joe, you're on the call. I don't know if you want to jump in at all and add anything or not. You don't have to, but I'm just going to give you that option if you're there. You may have stepped away. All right. Ah, there he is.
Yes, sorry about that. I'm actually at the vet office right now. So no, I'm good, but thank you. Appreciate the time. Hopefully this was helpful for you guys.
Yeah. So just to kind of recap, because I know we went over a lot. What are the bottom line benefits for patients, clients, and cases? First of all, you know that simple sprain strain are really hard to settle, right? You get all kinds of pushback. It's self-limiting, all different kinds of arguments that the insurance carriers have. This gets it out of simple sprain strain. there's a whole nother diagnosis that when patients have this injury, that's not sprain strain. There's literally a spinal ligament instability diagnosis. This injury adds value to cases even if there's a disc, even disc injury cases. Now, 41 to 44% of providers that are using X-ray are still missing this injury, and we saw that in the International Journal of Spine Surgery literature study. MRI has absolutely no shot at all to even detect this injury because it's not a motion test. So to recap, we need a motion test. Permanent impairment is one of the highest value drivers in all of personal injury cases. And so this injury has the potential for permanency. This is missed by a majority of PI treating providers. I can tell you that almost 80%. Part of what I do is to train providers how to do better in personal injury. I literally do seminars and webinars and online training, and I've actually been asked to come in and work with attorney groups and all kinds of different med legal conferences, and I'll ask providers, what are they doing for spinal ligament instability? And only a handful are raising their hand. The majority are not even looking for this. And so you already know as a representing attorney that you can't make stuff up if it's not in the records. If the injury is not diagnosed, you can't use it. And I can tell you that about 80% of providers are not even looking for this. And if they are, then the next step is of that 20% that are looking, they're using antiquated technology that's not able to identify this injury at the high level and also quantify it and also to document it reliably, accurately, and everything else. If you're an attorney, this can help to document your client's damages claims, create a causation link, and helps to create liability policy limits demand and can open up UIM if you're in a state that stacks UIM. In our conversation that I mentioned last week in our webinar with Jim Mathis, I asked him directly about the policy limits and how quickly attorneys could potentially settle. Bringing this, identifying it, documenting, quantifying, going through the whole process and bringing it to the carrier, in his estimation, 90 to 120 days to be able to settle cases without a long protracted healing time or all these bills from chiropractors and pain management and all of these doctors that sometimes all of a sudden turn cases upside down. Not that the patient can't get that, but it changes the way you approach your settlement when you have something like this. Now, this is again whether the patient has a positive or a negative MRI. And just to remind you that the ligament takes less force. So with a positive MRI, say you had a positive MRI, have the test done because you're missing that ligament injury. The patient had a negative MRI, but you can't figure out why they're still in pain. Have the test done because there's probably a ligament injury. And the only way to get this done is through the motion testing. So that's kind of just a little bit of a recap. Any other questions? It looks like we do have some other questions. So send us the PowerPoint or copies of the studies. Yeah, so I'm just going to put in my, type in my email here for everybody. And so I'll send that, just make sure I got it right. Okay. So it's Dr. Scott at drivingforcecompany.com. And if you do want sample reports, obviously they'll be redacted for both the cervical and the lumbar And we'll also send you a link to some literature. So go ahead and just email me and we'll be more than happy to get that out. But I do want to give a shout out and appreciate Joe putting this together. Any other questions, let me know. But hopefully this has been beneficial. And again, it's already in Utah, and there's going to be more units and more VMAs available. But if you have clients that you're thinking of, one of the other questions that I asked, and sometimes this comes up, is I'm only going to use this on my my higher policy cases, my minimum policy cases. Well, in according to Mr. Mathis, the standard cases nowadays with minimal or even disc issues are only settling in the the $7,000, $10,000, $15,000 range. In order, even 25,000 is minimum, I believe, in places like Utah. In order to get to that 25, you have to be able to show, objective findings and show evidence. So it's a consideration even in your lower end cases as well, or your minimum policy cases, because you might be able to stack UIM, and then that changes everything for you as well. So, all right. Well, any other questions? Hopefully this has been beneficial. If not, I want to thank you for being here. Again, you have my email if anything comes up after the event, and you can also reach out to Joe as well. And hopefully we'll be able to get some cases and some tests done for you right there in Draper over at Dr. Richard Allen's office as well. So thanks again, everybody. Take care, and we will hopefully talk to you soon.